You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about inflammatory pericarditis. We'll talk about pathophysiology, diagnosis, time course definitions, etiologies, treatment, recurrent pericarditis, and post-MI pericarditis. Let's get started with pathophysiology. Pericardial damage causes release of pathogen-associated molecular patterns, or PAMPs, and damage-associated molecular patterns, or DAMPs, which stimulate an inflammatory response by binding to toll-like receptors, or TLRs. NF-kappa B upregulates transcription of cytokines required for the functioning of the non-like receptor family pyrin domain containing 3 NLRP3 inflammasome, a protein complex that initiates inflammatory cell death and triggers the release of interleukin-1 beta and interleukin-18. So all this is going on when your patient presents with pericarditis. Diagnosis requires at least 2 of the 4 criteria: pericarditic chest pain, pericardial friction rub, ECG changes, or pericardial effusion. Pericardic chest pain is chest pain that is retrosternal, worse supine, better leaning forward, worse with inspiration, sharp stabbing, although it can occasionally be dull as well, lasting hours to days, unresponsive to nitroglycerin. It occurs in 90% of pericarditis patients. A pericardial friction rub occurs in 33% of patients, and ECG changes occur in 80%, which I'll go over shortly. A pericardial effusion is usually trivial or small in pericarditis patients and occurs in 60%. Supportive features for diagnosis are elevated ESR-CRP or WBC and evidence of pericardial inflammation by CT and MRI. So note that these inflammatory markers are not actually part of the 4 core criteria for diagnosis. The parietal pericardium is electrically silent. The characteristic ECG changes of pericarditis, which are seen in 80% of patients, derive from inflammation of the epicardium and the adjacent myocardium. It begins with widespread PR depression and ST segment elevation in all leads. The J point will return down to the baseline before the T waves begin to flatten. Subsequently, the T waves will invert before normalization of the ECG. As for the pericardial friction rub, the friction rub can have up to 3 components during atrial contraction, ventricular systole, and early diastolic filling. The 3-component rub is uncommon to hear outside of uremic pericarditis. More often, only a 2-component pericardial rub is heard. 60% of patients with acute pericarditis will have a pericardial effusion, as I mentioned, that's generally mild. The absence of a pericardial effusion should not exclude pericarditis, since 40% of acute pericarditis will have no pericardial effusion. How do we define pericarditis based on its time course? Acute pericarditis refers to an event that's lasting less than 4 to 6 weeks. Incessant pericarditis refers to an event that exceeds 4 to 6 weeks without remission. Recurrent pericarditis refers to new signs and symptoms of pericardial inflammation after a symptom-free interval of 4 to 6 weeks. Chronic pericarditis refers to pericarditis lasting for more than 3 months. In terms of etiologies, 85 to 90% of pericarditis cases are idiopathic. 8 to 14% are infectious, from viruses such as parvovirus and EBV, Epstein-Barr virus, which makes up 1 to 2%, bacteria make up 1 to 2%, and there's tuberculosis, which is much more common in developing countries. Other etiologies of pericarditis include cancer, more often from the lung compared from the breast, autoimmune, which can be lupus or rheumatoid arthritis, post-myocardial infarction, thyroid disorders, uremia, and drugs such as procainamide, INH, or hydralazine. In developing countries where tuberculosis is prevalent, tuberculosis accounts for about 70% of pericarditis diagnosis and has a high mortality, 25% mortality at 6 months in the absence of HIV infection, and 40% mortality in those with associated HIV infection. Tuberculous pericarditis is much less common in developed countries. Histoplasma capsulatum, endemic to the Ohio River Valley, rarely causes pericarditis, but is nevertheless the most common cause of fungal pericarditis in immunocompetent patients. Staph aureus infection should be considered in patients with recent instrumentation of the pericardium or cardiac surgery. Testing for tuberculosis with either tuberculin skin test or IgRA is done if the pericarditis patient is either from an area endemic for TB or is immunocompromised or HIV positive. A pericardial effusion may occur in 5 to 30% of patients with hypothyroidism. You would see high TSH level, relative bradycardia, and low QRS voltage on ECG, but not necessarily a pericarditis. The treatment for pericarditis is colchicine 0.6 milligrams BID for 3 months. Unless the patient's weight is less than 70 kilograms, then once daily of 0.6 is fine. And ibuprofen 600 to 800 milligrams TID for 1 to 2 weeks, or indomethacin 50 milligrams Q8 hours for 1 to 2 weeks until symptoms resolve, then taper over 1 to 2 weeks. Remember to add a PPI since you're giving so much NSAID. Aspirin 650 to 1000 milligrams TID is used instead of NSAIDs if it is post-MI pericarditis, CAD, or there is concomitant antiplatelet or anticoagulant treatment. Prednisone 0.2 to 0.5 mg per kg per day times 2 weeks, followed by taper over 2.5 months, is used instead of NSAIDs if the patient is refractory to 7 days of NSAIDs, or NSAIDs are contraindicated for some other reason, or if it is a recurrent pericarditis episode, or if it is uremic pericarditis or pericarditis due to connective tissue disease. The 3-month duration comes from the ICAP trial of 2013, which showed that the recurrence rate was halved from 37.5% in the placebo group to 16.7% in the colchicine group, giving a relative risk of 0.56 and a number needed to treat of 4. For recurrent pericarditis, the 6-month duration comes from the CORP2 trial of 2014, which showed the recurrence rate was 22% in the colchicine group compared to 43% in the placebo group, with an R relative risk of 0.49 and a number needed to treat of 5. You want to avoid steroids if possible because there is a high risk of recurrent pericarditis if they are tapered too early. So that brings us to recurrent pericarditis. The diagnosis of recurrent pericarditis needs three of the following: a documented first attack of acute pericarditis according to the above diagnostic criteria, a symptom-free interval of 4 to 6 weeks or longer, and evidence of recurrent pericarditis by recurrent pain combined with one or more of the following signs: pericardial friction rub, changes on ECG, echo showing new or worsening pericardial effusion, high white blood count, high ESR, or high CRP. So note that here in the diagnosis for recurrent pericarditis, white blood count, ESR, and CRP are allowed to be part of the criteria that supports your diagnosis for recurrent pericarditis. 5 to 15% of patients with acute or recurrent pericarditis may have a systemic autoimmune disease such as lupus, Sjogren's, rheumatoid arthritis, or scleroderma. Pericardial involvement is usually not the first manifestation of these autoimmune diseases. ANA antibodies should be obtained if pericarditis occurs in a young woman who has risk factors for rheumatologic disease. Recurrent pericarditis occurs in 15 to 30% of cases and can be as high as 50% of patients who are not treated with colchicine initially. ECG in recurrent pericarditis is often nonspecific and may not have ST elevations, so the diagnosis of recurrent pericarditis is a clinical diagnosis. Now let's talk about post-MI pericarditis. Post-MI pericarditis, which can be seen as soon as the first day after myocardial infarction, may not have ECG changes and can be diagnosed based on the patient's description of pleuritic, positional chest pain that can radiate to the trapezius bridge and or a pericardial friction rub. Dressler syndrome is a particular form of post-MI pericarditis that occurs 1 to 8 weeks after the infarction, whereby the pericarditis is accompanied by malaise, fever, leukocytosis, elevated inflammatory markers, and pericardial effusion. So you want to watch out for this malaise and fever and the timing of 1 to 8 weeks after infarction. If this chest pain is occurring the day after infarction, it may be post-MI pericarditis, but it's not Dressler syndrome, usually. Okay. Remember, post-infarct pericarditis, including Dressler syndrome, cannot get NSAIDs such as ibuprofen, nor can they get glucocorticoids such as prednisone, especially within the first month after MI, because NSAIDs and glucocorticoids cause myocardial free wall rupture, infarct expansion, and scar thinning. So, these patients with post-infarct pericarditis, including Dressler syndrome, can be treated with high-dose aspirin, 650 milligrams TID, plus or minus colchicine. Post-MI pericardial effusion are more often found in patients with larger infarct size when congestive heart failure is present and when it is anterior MI. Post-MI pericardial effusion rarely progresses to tamponade. Lastly, can athletes who develop pericarditis play in competitive sports? According to the AHA-ACC 2015 scientific statement on eligibility and disqualification recommendations for competitive athletes with cardiovascular abnormalities, athletes with pericarditis, regardless of its pathogenesis, should not participate in competitive sports during the acute phase. Such athletes can return to full activity when there's complete absence of evidence for active disease, including effusion by echocardiography, and when serum markers of inflammation have normalized. For pericarditis associated with evidence for myocardial involvement, eligibility should also be based on the course of myocarditis. Chronic pericardial disease that results in constriction disqualifies the person from all competitive sports. This is a Class 3 statement. Interestingly, they lumped all of the above together as one single statement recommendation. That's all I want to tell you about inflammatory pericarditis.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.